Welcome back. Thank you for sticking around for the graveyard slot. I know it's always difficult to make it to the end. So we have heard a lot of really interesting things today about various different initiatives, strategies, government policies that are happening or consultations. And we're going to finish today by talking about the NHS 10-year plan and thinking about what that means in the area of brain injury. And I'm lucky to have James Birch, Kate Roach and Luke Griggs here. We don't have time to talk about every single aspect of the NHS 10-year plan. We would be here sometime. So we're going to pick a few choice bits from that fits with the work that they're doing. But before we start, I'm going to give just a brief overview of some of the key points around the NHS plan. As I said, I'm going to try and keep this brief as I can because, as you can see, there's a lot there. So really, the underpinnings of the NHS 10-year plan was the idea of fundamentally moving away from hospital-based care and much more towards community care. So trying to get people out of hospitals and dealing with long-term conditions within a community area. Now, that has the idea of more care in the community, but it also links to things like involvement with voluntary sector, as we've been talking about already today. Thank you for whoever got my slides up on my screen. That's very helpful. So that's part of what we're going to be talking about today, and we're thinking about how that fits within the world of brain injury. Part of that process is thinking about things like the workforce expansion, as we've talked about already today, how digital innovations might actually help us to provide better support across the board, particularly in areas where perhaps we don't have the infrastructure that we need to support people effectively. One of the top ones there is obviously around prevention and health inequalities. We're never going to be in a position where we're going to be able to prevent everyone who might have a brain injury from having one. But certainly we can be thinking about ways in which we can reduce the likelihood of that happening, but also how we can better identify those individuals who perhaps are more susceptible to experiencing brain injury. So thinking about some of the things that Hope said earlier about children who might be more susceptible. We've also touched on today this idea around mental health. We know that people with brain injuries are much more likely to experience problems with mental health, and we know that they're also struggling to access those pathways. The Minister identified quite clearly her vision of care being much more personalised as we move forward into the future, and I think that's something that all of us would wholeheartedly support. Obviously, the idea is to try and make this system more financially sustainable and efficient. I would imagine, as far as the government's concerned, that's probably at the top there. And there's obviously a great need for that because we're living in really tight financial times. And then the final point of this was around this idea of research, innovation and data. And we've talked a little bit throughout the day about the need for better data, more routinely collected data that allows us to have the evidence base to do some of these future initiatives. So I thought it might be helpful just to map that slightly against what we came up with from the economic report, which Jennifer spoke about earlier. So obviously the key point of that was this idea of a right to rehab, that everybody within the UK should have the right to some form of neurorehabilitation. But we know that we are a very long way from having that happen. Better data will certainly help to support things like commissioning moving forward, and that was part of the recommendations from the economic costings, and the systematic collection of that data so that we can start to put together a much clearer picture of where the need is and where we can put intervention into place. One of the key things that we need to be thinking about is how the voluntary sector can help us support us here, and that's part of the reason why Luke is here today, to talk a little bit to that point. But we know that that's an ever-evolving landscape and not necessarily a positive one. And also James is here because we're going to be having a little look at how digital advances may support us in this rather long and quite difficult journey that we've got going ahead. But before we start that, I'd like to begin by thinking about community neuro rehab more generally. And so I'm going to go to Kate first. So Kate, could you talk to us a little bit about the kind of developments that are either happening at the moment or that you would like to see happening in the field of community neuro rehab that you think might form helpful support that fits with this 10-year plan?
I think one of the key things from the 10-year plan is moving services from hospital into the community, much closer to where people actually need them. And we've heard from a number of speakers today talking about their experiences, both negative and positive, about coming into those community services. On the negative side, there's been talk of long waits between having injury, being in hospital and coming into those community rehab services and being missed. So that pathway not existing, meaning that people don't naturally move from the point of diagnosis into the rehab that best suits their needs. So I would hope from the 10-year plan that there would be more of a move for some transition services. So, for example, there's a number of places across the country, but it's very much a postcode lottery like we talked about today, where there are posts that go and look for the people at the point of diagnosis. So practitioners from ABI teams who go into A&E and work out where the clients are that aren't reaching the community services. And they provide that support during that transition period of being discharged from hospital to the point where people start the assessment and intervention process for community rehab. I would really like to see a strengthening of those kinds of posts so that people who really need that early support can be identified and have some of those needs started to be put in place by the time they arrive in community rehab services. From our point of view in Buckinghamshire, where I work, we have one of those persons. Absolutely essential worker, works really, really hard and prevents a huge amount of deterioration where there's a high level of need and high level of risk whilst people are waiting for the time to come into our service. And that worker supports people through that time, identifies social care charities to get involved with, signposts people to appropriate services, provides family support and information during that time, which means that we don't have to start all of that process when people arrive in community rehab. We can hit the ground running with assessment and appropriate intervention. So yeah, that's something I would like to see more.
Great. And as you say, unfortunately, there's a bit of a postcode lottery. So can you give us a sense of how many of these sorts of services exist across the UK?
I'm not entirely sure. I know talking between services, it's very much a yes or no. Some people have them, some people don't. And it's completely down to the service and how it's commissioned in your area.
Okay, yeah. So then thinking about other strategies that may be of use, obviously the financial sustainability is a key focus here. Are you aware, or perhaps other initiatives that you might be working on at the moment in your neck of the woods that might be considered to be appropriately cost effective that you think you would like to see perhaps rolled out elsewhere?
I think a mixture of one-to-one and group intervention is really effective, we find, for helping people through their ABI recovery journey. Groups particularly around kind of having that peer support, which helps people with the emotional journey that they're on, having other people that they can share ideas with. And obviously it helps people to share things that are working for them within rehabilitation. And you know, for practitioners ourselves, it's a really time-effective way of working with a lot of people at the same time. So from a cost efficiency point of view, we know that groups are very, very effective, but we also know from outcomes too that people who have the option of groups alongside their one-to-one rehab tend to have better outcomes in their rehab. So again, at the other end of the cost effectiveness, it's a much more cost effective way of providing a service because it's a more effective service.
Sure. So there's things about that model that work better potentially for people than having purely one-to-one work.
Absolutely, yes.
Yeah. Okay. So Luke, obviously there's been a lot of talk today about this idea of how voluntary sector can support with the NHS 10-year plan. Headway are the predominant players in that particular arena here. So in your role as CEO of Headway UK, I mean, how do you see that working?
Well, I've been with Headway for 18 years or so now, and I can't recall a more difficult time from a funding perspective. And yet, you look at the services that local Headway charities are providing for the state, and without them, the reality is that things would fall apart, families would fall apart, and it is so frustrating, I think, to continually have these conversations over the years and over the decades to talk about the fact that the charity sector is providing that service for the state, and yet it is not based on a sustainable funding model. And obviously, since COVID, when we've said cost of living increases going up, rampant inflation combined with deterioration in fundraising opportunities, and local authorities and ICBs just simply not being able to keep up with those cost increases. Costs go up, income goes down. It's quite a simple economic model to look at. So, the conversation, we're looking at a picture now where too many local Headway charities have had to close their doors in the past 18 months, 2 years. I've been today helping another relatively large Headway charity. Have then made the very difficult decision that they are no longer financially sustainable, and we're trying to work with their local authority to keep Headway services running in that county. It's a difficult picture. So it was really positive to hear the Minister talking about working with charities, working in the community, whether it's to deliver those services, talking about how they're the heart of everything that needs to happen going forward, but also in concepts such as returning to work after brain injury education, vocational rehab. Local Headway charities are perfectly well positioned to do that. Or helping with the criminal justice system. We're working on some innovative projects with probation services to help brain injury survivors who are coming out of prison to better understand the effects of their brain injury and how it changes their behaviours, so we can prevent reoffending. So, we need to make sure that we're working with government to tap into those, to find innovative new funding pots, because ICB funding, local authority funding, is no longer sustainable on a local level. And I have real concerns about the sustainability of the local Headway network going forward, unless something changes quite quickly.
Yeah, so you're seeing some potentially positive initiatives, but the point is that, as you said earlier when we were discussing this, that if things continue the way that they are at the moment, there's a very real prospect that Headway will not exist as a series of organisations.
Certainly not in the way we look at it at the moment, because I'm dealing with regular conversations with so many local Headway saying that we can survive for this year, but... and we're trying to work, so we in our role at Headway UK, we're working very collaboratively with all the network to see if we can link up various different Headways as to have more collaboration, sharing back office functions, for example, or doing joint funding bids as ICBs get larger and what have you. So we're working very hard to make sure that there will be that sustainable model, and we will fight tooth and nail to make sure that obviously continues. Yes. But that community-based service, as you were just saying there, the togetherness. So when we're talking about community rehab, for me, when it's talking the 10-year plan, or what the Minister was saying earlier, it's really vital that we define what we mean by community rehabilitation. Yes. Is it rehabilitation that's in your community, or is it rehabilitation with your local community? Because it's not enough to just say that we want people to be discharged home after having some acute rehabilitation, which is hugely important at the early stage or when that's right for them, and then being discharged home, and then maybe having some support in their home to help to relearn how to cook, or be independent, or to clean, or to create a meal and what have you. That's wonderful, but it's not going to help people to regain their independence. It's not going to help them to relearn how to play an active part in their local communities, to get that confidence, to actually rediscover some sense of self or purpose in life. It's not going to help the carers or family members to rebuild their lives and to adapt to life after brain injury. So coming together, being in a place where you can be with others who understand what you're going through, you don't have to apologise for who you are. That's a huge part of that process of rebuilding one's life after brain injury. And we are running the risk of losing a central part of that for the sake of saving short-term savings. The long-term pain is going to be huge. So, we have to continue to work with the government to find innovative solutions and keep banging that drum to say that the 10-year plan or the ABI plan isn't going to work if there are no community-based services left to deliver it.
No, indeed. Potentially quite bleak picture at the moment.
But there is positivity there, because there really is. Because we're in these projects, and we need to find new ways to unlock different kinds of funding.
Yes.
So maybe working with the Ministry of Justice to actually have a central programme that we can work with the local Headway network to deliver for prisoners and probation services, to persuade the government to commission services on a national level, again working with the Headway partners across the UK for vocational rehabilitation. We just need to be really, really creative. And there is also some fabulous pockets of work going on across the country from local Headways who are defying the odds and continue to make such a difference in people's lives. So when we do have concerns about local Headways potentially closing, the amount of people who step forward and say, Headway is my lifeline.
Yes.
You know, there's some fabulous work going on, and we will continue that. It's just every day, that battle, and it's a fight worth fighting, of course. But we have to keep painting that, but we have to be realistic and say to the government, this is the reality. These charities are closing, and we damn well don't want any more to close, thank you very much. So you need to work with us.
Yeah, indeed. So James, moving to you last of all, obviously the focus within the 10-year plan is this idea of digital first, of moving much more towards digital innovations. What do you see being, well, I mean, obviously there are things that are happening, so perhaps you can talk us through some of the things that you feel are happening in this field, but also what the potential might be for the future.
Yeah, I think even today at the conference, there's some great examples of huge advances in innovation, both very directly affecting the patient in their care setting. I think we're all sort of seeing in our daily kind of experiences of tech, the onset of AI. I think wearable technology, robotics was mentioned earlier by the minister. And I think there's a lot of great examples that are already kind of in play or on the innovation pathway. And I think NIHR was mentioned earlier in terms of, I guess, opportunities for research, and certainly we've benefited from that sort of as a funding opportunity. And UKBIF, the innovation awards that are run here that we were fortunate enough to win a couple of years ago. So I think there's so many great examples, both that are directly impacting patient care as we move to this kind of neighbourhood community setting. The concept of virtual wards. There's technology solutions that are available on your smartphone for the patients, for family members, for the clinicians, which is our focus. But I think the sort of technology bit in some ways is the easy part. I think we do need to continue to give opportunities for the problem and the solution to have a meeting point, and there needs to be funding and enough opportunities for innovators to really get working with the right people to take the product to a point where it can be truly tested within a clinical setting. But I think there's a lot of other challenges around the 10-year plan that are probably not so much technical, but so much more around infrastructure and communication that I think is going to be the big challenge, because a lot was spoken around data-driven insights, which is absolutely the way forward. Data, if collected in a consistent way, can drive evidence-based decision making, which is what we want to see. But there's so many of those sort of bits of the infrastructure that need to be, I think, put in place. So I think it's a great plan. It sounds good, but everybody, I think, that works within some part of the care pathway for patients, particularly with brain injury, will know that bringing digital or bringing innovation into a space where patient first care and focus on what they need is not straightforward at all.
No, indeed.
I mean, I think there were some examples said earlier by the minister in terms it should be as easy as ordering a takeaway or whatever it might be, but I think us building that structure in place is so vital, and there's a long way to go on that.
Very personal interest in this as someone who's done tech stuff before and come up against the problems of NHS commissioning, where you've got a digital first solution. Obviously, some of what we've just been touching upon here is around commissioning issues within the NHS as being part of that infrastructure that potentially causes difficulties. Is that something that you have experienced as part of the work you've been doing?
Yeah, I think positively, I think we've been able to see that when you can bring data together in the right format for commissioning, we've got some examples. I was chatting to a colleague from RHN in Putney, where they're seeing very tangibly examples of that conversation with commissioners around funding, for example, sort of one-to-one care that needs to be put in place for particular individuals where there are very complex and challenging to manage behaviours that are at play. If you get that data together for the commissioning discussion to talk about the funding, then it can become a much more straightforward conversation. So I think that's a real positive.
Yeah.
But I think in the absence of that, the back and the forth of trying to provide the right sort of evidence can be a real challenge. And then that is kind of exacerbated across the whole kind of care pathway, isn't it? So
yes, yeah, absolutely. Okay, thank you. So just to try and summarise some of this and to think about other areas where you might want to be looking at, I put together a slide. I'm certainly not suggesting these are the only things that we need to be thinking about, but perhaps some of the initial stages. So obviously we've been talking about digital solutions, so looking at how we can support rehabilitation, particularly in the home environment, once people have left hospital, when we know there is a distinct shortage of any formalised support at the moment. We've talked about this idea of data, and one of the things that hopefully the conversations that we're having around the action plan will elucidate is how we can put better infrastructure around making sure that data is adequately collected in the first place, but also how we get access to some of that secondary data that's really important for being able to map the effectiveness of different services, or understanding the groups that we're actually dealing with, the size of the problem. But I think I'd like to put out a call to organisations that are out there, particularly if you work in organisations that are a bit more based within the private sector. The chances are you are sitting on a wealth of data already that would be really useful for us to, as researchers, to be able to tap into, to be able to demonstrate the effectiveness of some of the things that you guys are already doing on the ground. And I think one of the problems is that we're all so busy in our day jobs, clinicians and researchers, that we don't necessarily form those useful collaborations to come together and make sure that that data is being utilised in the way that is incredibly effective for us to do so. So that would be something that I would leave you with today, of thinking about how you as a clinician or your organisation might be able to work with different organisations, different academics, researchers that might make that happen, or within your own organisations. So there are examples of things like that that are going on around the country, where those sort of smaller secondary data sets are being used quite effectively to be able to demonstrate certain services and how well they might be working. I think one of the things here, and this is certainly talks to what Luke was saying about this idea of actually meeting other people, and certainly what Kate was saying about this need for a group-based intervention, is that there's this wider idea of social connectedness, that community neuro-rehab is such an amorphous term, and I don't think any of us really have one finite definition that we can give of what that means. But certainly a large component of that should include this social connectedness. It should be reducing social isolation, helping people to get back within their local communities and reintegrate effectively. And I think one of the things that we really need to be considering moving forward is more innovative, potentially low-cost solutions that we can actually offer those sorts of services up that aren't necessarily formalised neurorehabilitation as we would expect to see within an NHS context. That is great. We need those services too. But we all know that with money being as tight as it is, we're probably not in a position where we're going to be able to offer those sorts of services to everybody. So we need to be thinking about the potential other options that we can employ. I'm minded of awareness raising. So we're sat in this room, all of us know about brain injury, we know how serious the problem is. I thinking about Hope's talk, and she said, everyone she talks to outside of brain injury, how serious is this problem? If I had £1 for every time somebody said to me, well, brain injury, it's quite a niche thing, isn't it? I wouldn't be stood here today because I'd probably be in the Caribbean. It's not niche. We all know it's not niche. But actually, there are millions of people out there in the world around us who don't know that it's not niche. And we need to be making sure that we're telling the general public that this is a problem, that we are making sure even our health professionals in A&E settings know that this is a problem, that all of our health professionals and our social care professionals and our education professionals and our criminal justice and probation, etc., that they know this is a problem. And I think it's something that we quite often feel has been done to death, but that's only because we're living in this echo chamber. Actually, we've still got a really long way to go. And then the final thing that I wanted to point out was this idea of the single point of access that came from the NICE guidance. And I think some of this idea of how we look at case management as a model is incredibly useful. But thinking about the fact that there are small level initiatives that are already happening within the NHS where these single point of contact approaches are working, albeit on a very low level. So I'm minded personally from the work that I've been doing with local headways of the hospital liaison support system, where somebody goes into the hospitals and helps to signpost people as they're coming back out. Now, they weren't really necessarily designed as a single point of contact, but that's effectively the kind of model that has grown up from that. And your service that you were talking about is a similar kind of thing, of this being able to offer that bridging into a community environment. So I think we need to be thinking about those sorts of strategies as an initial stage of how we might be able to support people better on the ground. But I'm sure there's plenty of other things as well that we need to be thinking about. I'm not sure where we are for time. I've got a few minutes, so I don't know whether Andrew's got any questions from the audience that he can pull up. No question. Does anyone actually have any live questions that they'd like to pull up in the few minutes that we've got left? Otherwise, I'll hand over to Andrew. Well, I can actually see a thing from here. No, I can't see any hands. Everyone's thinking that was lovely. Oh, yeah, okay. Yeah. Yeah, give it a go. I'll see if I can hear you.
My name's Nick. I'm working in Health Improvement Services in Wales and Constant Improvement. And our version of the 10-year plan is Primary Care Model for Wales, which talks very much around an integrated community service, or trying to community pathways to the community to maximise the recovery, so place-based, not in the secondary care setting.
Right, yeah.
And there's a big shift around conversations around community by design.
Yeah.
Trying to support an integrated workforce to maximise people's, to maximise the resources by people working. I just think it touched on a few different points that you made there earlier. And also, we're trying to support the embedding of third sector services into service specifications in some of the networks that we're involved in, to try and ensure that health services bolster around what's currently available. But I appreciate the funding for those services is digital.
Yeah.
Which may make that more difficult to therefore.
Yeah, okay, thank you. So for any of you who weren't able to catch that, effectively they're talking about the Welsh model, where you're building networks of various different health professionals, but also social care and voluntary sector workers within communities that can provide an integrated service. Yeah, which sounds absolutely fantastic. Okay.
Sorry, just to kind of follow up on what you were saying about integrating voluntary sector within healthcare service, I think that's something that we should in the NHS be looking much more at. One of the things that we do around particularly our group therapy is we partner with local charities. So our groups some of our groups are activity groups, OT-led activity groups, where people work at a local charity, embedding the skills that they're learning within their neuro rehab into real life settings. And I think that's one of the really key things that NHS services need to be doing more of, definitely.
Yeah. Absolutely. Lovely. Great. Thank you very much for listening. Thank you very much to the panel.
Just stay there. Yeah. Okay, so Ali, thank you so much. I thought that was a really well thought through session, and I really enjoyed your slides. I think they're really nice ways of helping us think about the future. So look, folks, I haven't got a long wrap-up thing to say. I think my brain's actually a bit full. I've really enjoyed the day myself. I hope you have. You'll get an email about the inevitable feedback thing. The feedback is really important to us. I think today's been great. I'm biased. It's been like it is because of feedback in the past. I think it gets better each year, but you do need to tell us, what have we missed today? What did you want, to get out of today? Just as a kind of little curious hand showing thing, just to see if you're still alive, can you put up your hand if this is your first United Kingdom Acquired Brain Injury Forum meeting? That actually is fabulous from my point of view. Thank you for coming. Thank you very much, because we've been coming now here. This is our 3rd year in Manchester. We love this venue. We think it's great to come here and meet people, and I think it creates a space for community and connecting. So I'm hoping you've come today and met people that you've not met before. I'm wondering if there's something you've heard today that will make you do something different, okay? And just to kind of help you embed that, as you leave, I'd like you to tell somebody that thing. What are you going to do differently as a result of being here today? I'm going to say 2 things. One is, if you haven't already done it, do your membership form on the UKBIF webpage. The other is to write to your MP. So they're my instructions, but there might be something else that you want to do differently as a result of today. So my takeaway is that we've pulled together, we've had adult and child services, we've really thought about some very exciting developments in the science. I think the work that Professor Manley talked about this morning is going to really stay with me in terms of the emerging work on biomarkers, especially, and I think that those points that you've put there, Ali, will feed into tomorrow's research strategy meeting that we're going to be working on. But that's just the start of some of you may have seen the press releases. We're very early days in this, but Ali and I are launching a NIHR-supported brain injury social care incubator. And the idea there is that the NIHR have given us this little fund to help us incubate research in the social care system. There's a lack of capacity, lack of research capacity. So we need to help people develop their research skills, their research opportunities, and apply for NIHR research funding. And there's a group of us that can help you apply for the often mentioned research funding. And so please be encouraged that this data that Ali's mentioned that you have could be data valuable, could be financially, fiscally valuable to your system, because we need to be able to work with it and develop your ideas. And I think seeing those ideas into the NICE guidelines, as what we've seen today, is where we go over the coming years. And I think I really actually took something from that NICE guideline session, that now is when we, so like I was saying earlier, we were looking at the Time for Change manifesto from 2018. Here we are 8 years on. Now is not too soon to think about the next revision of the NICE guidelines. It takes that kind of time, but we've been working on it steadily. We're going to keep going. I said I wasn't going to say much, but I'm waffling now. So look, guys, safe travels. Hang around. We're not evicted from the building for a bit. Some of you are coming for dinner tonight, I hope. So there's a wonderful fundraising dinner tonight. If you're not coming to it this year, come to it next year, and see you at this time next year. First Monday in November. Okay.